Hi, everyone. This is Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. I want to welcome you to the Journal Club, and I also like to thank ESGO and IGCS for their support of our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's session, and the recording will be made publicly available. So participants with cameras turned on may appear in the video recording. So we ask that everyone please keep your microphones muted so everyone can hear the presentations. If you're having any difficulties or questions, please send a message in the chat and our technical support team will assist you. We will have time for questions and answers, and we actually encourage you to submit questions via the chat function throughout today's session. So this month's lead article is titled Racial and Socio-Demographic Disparities in the Use of Targeted Therapies in Advanced Ovarian Cancer Patients with Medicare. This is authored by Dr. Ann Knisely and Roni Nitecki, who are at the MD Anderson Cancer Center here in Houston, Texas. So I'm very, very pleased to welcome them to join us. Very, very proud and happy that they submitted their manuscript to our journal. So Ann, Roni, thank you for being with us today and sharing your insights into this really great article. And I'm going to hand it over to you now for a summary of the article.
Thank you so much, Pedro. It is such a pleasure and honor for us to be here. I've never done one of these, so I'm super excited.
Yeah, me too. Thanks so much for having us.
Excellent.
So obviously, it goes without saying we are presenting on behalf of our team. Anytime, one of these papers gets submitted to the journal, there's a lot of work that goes into it, and a lot of people that contributed to making this happen. So thank you to our entire team, and we are kind of presenting on their behalf. So the objective of our study was to describe the sociodemographic and racial disparities in receipt of PARP inhibitors and bevacizumab among insured patients with ovarian cancer. So the methods are very important to understanding the results of this study and kind of the implications. So this was a retrospective study, which comes along with all of the the limitations of a retrospective database study. We used the SEER Medicare database. We included patients with advanced stage high-grade serous ovarian cancer that were diagnosed between 2010 and 2019, and that during this time, we could prove through the database had consistent Medicare insured care and care that was built to Medicare. The primary outcome was receipt of a PARP inhibitor or BEV at any time after the diagnosis. We used kind of standard statistical methods, univariable analysis for the variables that we were interested in, and then multivariable analysis to kind of look at independent effects as well. And we did that using a multivariable logistic regression. So in terms of the results, our cohort included over 6,000 patients. 276 of those, or about 4%, received a PARP inhibitor, 34% received BEV, and 6% received both. On univariate analysis, the patients who received either targeted therapy were overall younger, had a lower comorbidity index, meaning they were more healthy based on what we could tell from the database, and had a higher socioeconomic status compared with those who did not receive either targeted therapy. In the multivariable model, non-Hispanic Black patients were less likely than non-Hispanic white patients to receive either targeted therapy. Older patients were also less likely to receive a PARP inhibitor or bevacizumab compared to those who were younger. So those are kind of the main results that we observed. And as you can see from the table in the slide, the use of these therapies had kind of increased over time, and I'm sure we'll talk more about that in the discussion and in the limitations of the study. So our broad conclusions are that sociodemographic and racial disparities do exist in the receipt of these targeted treatments among patients with advanced ovarian cancer that were insured by Medicare. And as the targeted therapies become more commonly used, a widening disparity gap is likely. And that kind of brings us to the reason that we wanted to look at this, this issue to begin with. And this is kind of a summary of the entire study. Happy to answer any questions that come up.
Excellent. So thank you, Roni, for that wonderful summary. And certainly, obviously, we want to start this discussion and addressing an important point. And I think, you know, just actually yesterday, somebody that I was speaking with from Spain, she highlighted how she found this article really very, very interesting. And she said, you know, why does this happen in the United States? You know, certainly shouldn't every patient have access? And particularly the question that she had was, why being a higher socioeconomic status in the United States gets you better therapy?
I mean, I think that kind of has a complicated answer that we don't know sort of all of the nuance to right now. But I think the bottom line is that, you know, we've shown, or others have shown, kind of in the literature in ovarian cancer, that when you have kind of equal care, you get equal outcomes. So kind of unlike some other GYN cancers where we think there may be some biologic differences. So I think that, you know, clearly there's a kind of disparate, kind of a disparity in access to care in this study, kind of probably in the recurrent setting, since most of these drugs were being used in the recurrent setting during the time period. So I think that, you know, others have shown sort of increased fragmentation of care in some of these more vulnerable populations. And I think one of the points that we'll probably address more with kind of future questions is, you know, access to both genetic counseling as well as molecular testing, which for PARP inhibitors specifically is sort of an important determinant based on the way that we practice in the US. So I think those are some of the factors. I think, you know, kind of lower socioeconomic status, you know, insurance in this case, everyone had Medicare. So in our study, at least, there's probably sort of some more nuanced and subtle differences in why these exist that unfortunately with this type of study, you know, we can't really fully answer because of the lack of granularity of the data.
Excellent. Very well. So we'll turn it over to some of our fellows, and we'll start with Elena Rodriguez from Spain.
Thank you, Pedro. Congratulations for the study. In the study, most of the patients included use PARP inhibitors or bevacizumab in the context of relapse. So I'd like to ask you if you assess whether there are differences in the rate of recurrence between different socioeconomic or ethnic groups, which could account for the difference observed between the use of these drugs. Thank you.
Yeah, you know, I think that, you know, as I said before, sort of, we know that equal treatment leads to equal outcomes. But I think the unfortunate reality is that these minority groups are less likely to receive guideline concordant care, which has been shown in previous studies, and more likely to receive treatment delays and fragmented care, resulting in disparate outcomes. Most of the outcome data we have in the literature is based on overall survival, not specifically progression-free survival. But I think if overall survival is worse for these groups, we can presume that PFS is also likely to be less favorable. So I think there could actually be more opportunities to treat recurrent disease in some of these patients, but the barriers to care, I think, especially in the upfront setting, tend to persist and lead to fragmented care in the recurrent setting.
Yeah. Excellent. And now we'll pass it on to Susana Del Frati.
Thank you very much, and thank you for your presentation. Mine is an ethical question. Determining the race or ethnicity of an individual or group of participants can offer insights into the generalizability of a study's findings. However, it is important to recognize that many individuals may identify with more than one race or ethnicity, so these categories should not be considered rigid or evaluated in isolation. And this discussion raises an important and timely ethical issue. Is it still appropriate to talk about racial gaps in scientific literature today? Thank you.
That is an excellent question. And I don't think it's unethical. I think it's an important discussion for us to have. You know, you're absolutely right. I will start by saying that. I think that unfortunately, when we talk about this database, we're sort of limited to the demographic data that we have. You know, as of now, I can't think of a database that has much better granularity and demographic data, and that is something that we should strive for, certainly in a country that has, you know, such a variety of ways to identify and kind of groups to be included in. Having said that, I think it's really important to still try to identify like who's getting better care and who's not, because the kind of interventions that would work in one population may not work in another. And so kind of as leaders in oncology, we really have to think about sort of how do we get the care that should be given to everyone to the patients that are getting, for whatever reason, are getting less of it, are getting not as high quality of it. And so that's where these database studies are really helpful in trying to figure out where the gaps are. And they're just hypothesis generating. You know, they're not really telling us what the problem is, but they're hopefully pointing us in the right direction. And I think our job is to kind of do the best that we can with the data that we have, and then have sort of thinkers like you that are thinking in a more kind of broad, inclusive, important way to think about how do we improve the databases that we have to apply to the vast majority of the population. So the truth is we're not there yet, but hopefully we will get there.
Yeah.
Okay, thank you very much.
Yeah, and I agree, and you know, certainly I recently was listening to a podcast with regards to why do we still include the race of the patients in the results, and someone who was not in the medical field was asking, why is it that whenever you look at a medical paper in the results, you often see, well, this many patients were of this race and of that race. And the point was brought up exactly as Roni was mentioning with regards to we need to have an understanding of where the disparities are in terms of the treatment, and where there may be a benefit to a particular group from a given intervention. So it's a very good point, and thank you, Susanna, for bringing that up. Now let's go on to our next question. Ali in Salt Lake City, Utah.
Congratulations to you both. Thank you. What are some of the hypotheses as to why older patients are less likely to receive PARP inhibitors or bevacizumab?
I think that, you know, in general, older patients are more likely to have medical comorbidities, frailty, worse performance status, which may make them less fit kind of for targeted therapies in general, as well as for combination regimens. Obviously with, you know, Bev specifically, it's usually sort of combined with other things. And so kind of I think about like an older, frail patient who you might be more likely to give single agent chemo to, or, you know, 2 agents instead of 3, things like that. And then I also think that, you know, objectively, patients with HRD positive ovarian cancer are more likely to be younger than those with HRD negative tumors. So I think it makes sense for PARP inhibitors, kind of on the other end, that they would be more generally utilized in a younger patient population. So I think those kind of factors probably help to explain those results.
Yeah. And I was wondering also, you know, when looking at patient populations and age of those patients, without you know, stepping outside of the boundaries of this database, and potentially even actually internationally, do you think these results reflect what is happening in other countries where these drugs are available to those patients?
Yeah, I think it's hard to know. I think that, you know, I would be curious to hear, you know, some of the people on the call, sort of what the practice patterns are. I know even within the US and within sort of academics versus private practice, the practice patterns in general for giving these medications is different. Obviously, for example, niraparib is approved for, you know, all comers in the US. But I think at academic centers, we're largely only still giving them to the HRD positive patients. So I would be curious to hear from people from other countries sort of what the general practice patterns are. I think that the disparities probably exist wherever we go. I think that, you know, unfortunately, decreased access to care at the time of these sentinel oncologic events is probably going to lead to less prescription of these therapies.
Yeah. I see, and I'll call on Sabrina. Sabrina, I see that she's part of the group in Canada. What is the reflection of this data, and what is your suspicion as it pertains to any potential disparities?
Thanks so much, Pedro. I was actually thinking of raising my hand virtually. So exactly. So in Canada, there is a disparity in that we tend to start niraparib without necessarily having the HRD available. Unfortunately, it takes very long to get the block, to send it off. It's quite complicated. I'm actually working on trying to improve that. But the trend in Quebec, where I work, and in Ontario has been to, start it, counsel the patients, and then once you get it back, like if their platelets haven't dropped and if they haven't come to the ER, or if they could still tolerate it, then, we do counsel on only the 3-month benefit in HRP and discuss whether we should stop it or not. That's pretty much the practice across. But definitely there has been racial disparities, and you could see there was a paper on endometrial cancer where African Americans and Black patients do have a higher incidence, and so I think it's still very important to report it, or at least try to include them in the studies for sure. Thanks, Pedro.
Yeah. And Sabrina, in Canada, do the patients have more restricted access to PARP inhibitors than they do to bevacizumab, or both are a challenge?
No, PARP inhibitors not, especially with there's still the patient support program for the HRD testing, and the reimbursement is all like a public system. It's definitely not a problem for funding, especially not for olaparib. For bevacizumab in the first line in ovarian cancer, we tend not to give it, as it's mostly reimbursed in one line of treatment. So we tend to keep it for platinum resistant. We do have trials where we actually have it now. But like in terms of funding, I would say like people tend to favor a PARP inhibitor in maintenance setting versus bevacizumab. I'm not sure in Ontario or if the med-oncs based on ICON 7, people push much more for that, but definitely where I am, the access to bev is quite limited.
Okay. All right. Very well. So thank you, Sabrina, for just jumping in and having me put you on the spot. So we'll go to Turkey. Mina.
Thank you. My question is, were there finding of disparities of the drug usage between region and Yost index?
I'm muted, sorry. Can you guys hear me now?
Yeah.
Okay. So great question. We actually did see differences in the use of PARP and BEV regionally that were statistically significant on both univariate and multivariable analyses. So patients residing in the US, patients residing in the Northeast, the South, and the Western regions of the US were significantly more likely to receive targeted therapy compared to those in the Midwest, with odds ratios between 1.4 and 1.5 on multivariable analysis. I don't know why people in the Midwest are like not giving these, but there was sort of a clear difference, which we thought was sort of interesting. We did not, kind of conversely, we did not find significant differences in drug usage based on rurality when we compared patients living in metropolitan, urban, and rural areas, which I think was a little bit surprising to us. And then for Yost index, just to sort of fill everyone in on what that variable means. The Yost index is a census tract level socioeconomic status variable that includes a number of different factors, including median household income, median house value, median rent, percent under 150% of the poverty line, education index, percent working class, and percent unemployed. The possible values range from 1 to, which is the lowest quintile, to 5, which is the highest quintile. So we dichotomize this variable into sort of low and high socioeconomic status, with low being quintiles 1 and 2 and high being 3 to 5. And found on univariate analysis that patients who received either targeted therapy were more likely to be of higher socioeconomic status compared to those who didn't. So I think sort of consistent with our hypothesis that kind of those with higher socioeconomic status, possibly higher education, may be sort of going to more specialized centers that are then, sort of more comfortable with prescribing these therapeutics, especially when they were first FDA approved.
And then, Anne, as a follow-up to that, you mentioned access to specialized centers. Do you have information as to whether this is that pronounced if you get treated in an academic center versus if you get treated in a private practice setting or a non-academic center?
Yeah, not from this database, but I think that would be interesting to look at because I would hypothesize that those would be different, just based on sort of, I don't know if Dr. Wilke has any kind of more information about that, but I think based on, you know, just in general, sort of newer therapies taking a while to sort of go out into the non-academic world, I think I would suspect that they were prescribed less, again, at least initially, right after FDA approval in the private practice setting.
There are also different reimbursement patterns depending on the insurance that the patients have and then the kind of insurance that the facility accepts. And so I think you would also see differences based on that. You know, one database that's really good to look at sort of facility type is the National Cancer Database, where you really can sort of drill down on sort of the different characteristics of facilities that provide certain medications, but we wouldn't be able to do this particular study in NCDB, but that's just an example of a database where you would be able to do that. But yeah, I think you probably would see kind of a lot of differences based on the type of facility where the patient is getting care.
Interesting. Okay. Next we'll go to Raikan Blatvikova.
Congratulations and thank you for the presentation. My question is, how do you explain that in table 2, the percentage of patients receiving PARP inhibitors and or both according to years did not increase, but actually decreased over the time?
Yeah, so kind of to orient everyone, table 2 displays the univariate analysis for receipt of target therapy based on different demographic factors in our sensitivity analysis, which only includes patients diagnosed from years 2014 on after FDA approval of both BEV and PARP inhibitors in the recurrent ovarian cancer setting. So this was just a smaller group that we looked at who kind of didn't get diagnosed until these agents were approved. I think there are small differences in the number of patients who received these therapies during those years, but overall, I think it appears relatively stable. Sort of the absolute differences in numbers are not very large. I will say that I would have expected kind of a larger increase, but I think we will probably see that once we have sort of the full data after 2018, since those drugs were finally approved in the upfront setting in 2018. And became sort of more integrated in standard upfront maintenance therapy, at least in the US.
Excellent. We'll turn to Roberta Massobrio in Italy.
Yes, thank you. In case of racial and socioeconomic disparities in BRCA and HRD testing, do you foresee that prescribing medications which could be indicated for all comers, such as niraparib, might be a strategy to mitigate these disparities?
I think that's a great question. So there are certainly pros and cons to sort of the biomarker agnostic approval for niraparib, regardless of HRD status. You know, on one hand, it makes drug more accessible to everybody, but on the other hand, it also makes toxicity more accessible to everybody. And so we really have to kind of weigh the pros and cons. And what does it mean to get a PARP inhibitor up front for the rest of your treatment if you're not in a group that's going to definitively benefit more from it? So those are questions that we, you know, kind of grapple with as oncologists every day. And I don't know that the strategy of kind of giving it to everybody would necessarily decrease disparities if the access to care in general is limited among certain groups. You know what I mean? So that's a strategy that I think would be interesting to look at if we could guarantee that everybody had access to the same care, but we know that's not the way it is. And of course, as mentioned, we kind of have to take into account the toxicities of these medications. And, you know, certainly from the changes in PARP inhibitor prescribing patterns in the past few years and kind of the approvals that were later taken away, clearly there's something that's happening with PARP inhibitors that we need to look more closely into in certain patient populations. So I think that's an interesting strategy, but I don't know that as of right now we can say that it would definitively decrease disparities.
Okay.
Yeah, it's an excellent point. And just you know, one of the studies that we're looking to start now is particularly to that patient population as to like who will benefit from these medications, and we're looking at values of circulating tumor DNA may help whether, you know, you can select which patients will actually benefit from these treatments. But again, of course, obviously, adding another component that may play into the disparities as well with regards to who has access to getting circulating tumor DNA testing as well. So more to come on that. Jose Vilches, who's one of our fellows as well, he's actually in a tumor reductive surgery now. I told him that he should have given the patient neoadjuvant chemotherapy. He could have been here for the journal club, but he's not. So we'll have Roberta ask the question for Jose.
Yes, Jose wanted to ask, what concrete steps do you think physicians can take to address these disparities in care?
Yeah, I think that, you know, leaders in oncology in general and gynecologic oncology more specifically really need to implement initiatives to improve equitable access to targeted therapies, or as we sort of alluded to in the beginning, I think the existent disparities will just continue to get worse with the routine use of these therapeutics in clinical practice. And that's actually what initially sort of made me interested, or made us interested in this topic is, you know, I'm kind of really interested in the clinical trial space, and there's clearly a big disparity there. And I'm like, as we get more and more sort of targeted based on molecular subtype, you know, all this, to me, that will just worsen the disparities that exist. So I think kind of on that, in that vein, a key area of focus should be increasing access to both genetic counselors and tumor molecular testing, as I think this is going to be more and more important for patients who may not have access to a cancer center or even sort of a large tertiary care center. So I think, you know, we know that there's a shortage of genetic counselors across the US and that they tend to be clustered in bigger metropolitan areas, just like all specialty healthcare. So I think it's important to ask, sort of with a fixed number and distribution of genetic counselors, how do we maximize counseling and reach kind of the most patients that we can? So I think current NCCN guidelines recommend that genetic counseling and testing be performed by a genetic counselor, a medical geneticist, an oncologist, a surgeon, oncology nurse, or another health professional with expertise and experience in cancer genetics. So obviously, kind of anyone with knowledge of genetics can be a proactive participant in helping patients get guideline concordant care. So for example, I think one well-documented and effective method to overcome disparities in genetic counseling, genetic testing is mainstreaming, which involves non-genetic healthcare professionals conducting pretest counseling and ordering germline genetic testing, rather than referring patients to genetic counselors, which can be sort of an extra barrier for patients that don't have that resource. Other models include sort of embedding genetic counseling within oncology clinics, making more broad use of telegenetics, and a whole host of interventions to help providers facilitate testing. Of course, most interventions to date have been implemented in academic medical centers that already have high rates of guideline concordant care. The few studies that have examined receipt of any genetic services among medically underserved populations show a consistent trend of lower rates of referral and testing among Black patients, those of Hispanic ethnicity, and those with limited or public health insurance. That's why it's extremely important to sort of study and implement interventions specifically among disadvantaged patients and communities to address this sort of health equity gap. I think, you know, beyond genetic counseling, I really do think that kind of molecular testing is really going to sort of be shaping the care that we give in the next, you know, decade or so in GYN cancer, obviously, especially in endometrial cancer, but I think it's just coming down the pipe more and more for all of our cancer types. And I think this is something we should be thinking about now in terms of how to sort of ensure that patients, or like, you know, put initiatives in to try to help patients in sort of less academic, less sort of cancer focused centers to, you know, be able to access this testing. And I think that's going to be a big hurdle.
Yeah. Very well said, Anne. And as a follow-up to that, and you mentioned one of your areas of interest is as it pertains to clinical trials. I think we would all benefit from learning as to how do we increase diversity in our clinical trials, and how do we get a more broader representation as investigators And I was wondering if you had any thoughts on that. And Roni, I'd love to hear your thoughts on that as well. Because as you know, obviously, as we're accruing patients onto clinical trials, that's a constant goal for all of us as investigators.
Yeah, you know, and the FDA is emphasizing it more and more. And it's I think really important for our patients. I think it's a challenge at a place like we work at MD Anderson, a place like Anderson where the patient population just isn't that diverse. I think it's proven to be very challenging. I think that the best way that we can sort of practically do it is to partner with other institutions to do sort of multi-institution trials where we're including other places that have kind of different populations so that we can try to increase diversity. I think doing a single institution study at MD Anderson is never really going to pick up a diverse patient population. And so I think looking outside of this institution, for example, and kind of partnering with groups that have more diverse patients is sort of probably the most effective way to do it in our specific setting. But I'd be curious what other people think, because it's obviously a big challenge.
Yeah.
Yeah. Anne is, you know, you're 100% correct. I think, you know, the type of patient population that we see at MD Anderson is kind of the patient population that comes to MD Anderson because they want to go on a clinical trial. So that's not a good representation of the entire country. I think you're absolutely right. Sort of deliberate inclusion of institutions that care for different patient populations is important, but it's also important to understand, you know, even if you have the best infrastructure in the world, you may have a patient population that's not interested in trials or doesn't trust that they'll get the best oncology care on a clinical trial. You may have patient populations where the barriers are different. So I think for every population, it's not a one-size-fits-all model. We have to really understand what the barriers are. And then once we understand the barriers are, then we have to implement effective interventions. So, you know, I think setting up the infrastructure, like Anne said, is kind of number one. We just have to make these trials available for patients so they even have the door to open. But then we also need to figure out sort of how do we help enrollment? You know, how do we help patients realize that most of the best oncology care is on a clinical trial, and it truly is something that could benefit them in a non-intrusive, sort of non-patronizing way. And I don't know that kind of as a society, we've kind of figured that out yet, but it's something that we need to look into and really learn from our patients and from community leaders within those communities.
Yeah, and I think extremely well said by both of you. And I think also, obviously, we put a lot of focus on the disparities in the demographics of the patients, but we often don't talk very much about the disparities in the investigators. That oftentimes the principal investigator pool on many of these trials does not reflect the population overall. So I think that's also really very, very important to highlight as well. I see that there's a question here on the chat, and it says, would there be any second database or any methodology that can look into language barriers for patients?
Gosh, that's a really good question. I can't, off the top of my head, I cannot think of a database that records sort of primary language or preferred language for a patient. It doesn't mean it doesn't exist. I just can't think of one right now. Yeah, that's an excellent question, and certainly another sort of granular detail that we would love to have for our study that we don't.
Leave it to Dr. Arthur Shu to always ask the very easy and simple questions. Thank you, Arthur. Really appreciate it. Well, so as we come to closure of this journal club, of course, obviously, we want to thank both Anne Knisely and Roni Nitecki. Any last remarks you want to make with regards to as to what are the points of interest pertaining to this topic moving forward? Any upcoming studies that you see or that you would recommend for our fellows or our audience to pursue in answering some of these questions?
Yeah, I mean, I think kind of the obvious next step to me, which I already spoke about a little bit, but really is people really need to sort of get in the weeds and partner with public health practitioners to understand how to, you know, implement interventions so that, we can increase access to both genetic testing and molecular testing. I think that, these are, just two medication, bevacizumab less so, PARP inhibitor is a better example of that. But these are, these targeted therapies, like I said, I just worry that the gap is going to continue to widen. And so I think really sort of thinking about strategic ways to set up, programs so that it's easier for patients who are not being seen at big cancer centers to get these services. I think those projects are going to be really important moving forward and worthwhile for potential, broader implementation.
All right. Roni?
I would like to also just kind of give lots of kudos to Dr. Ann Knisely. This was like a true passion project for her. She thought of it herself. She came to me with the idea and she really sort of drove the entire project. And I just, for the fellows that are listening, like as a mentor, that's like the most important thing, right? Is to have somebody who's passionate and who has a good idea. And certainly when you are interested in a topic and you care about it, that's when kind of the best research happens. So big congratulations to Anne, and I hope that the other fellows feel motivated to kind of follow their passions as well.
Excellent. Excellent. Thank you both so much. We certainly hope you enjoyed your time with us today. Thank you for joining us. Once again, I want to thank Anne and Roni and all of the faculty for their time, and would like to thank all of you for attending. Also pointing out that the recording of today's session will be available on the IJGC, IGCS, and ESGO websites. I also want to announce that please remember to join us in December for our journal club to discuss the article titled Optimizing Patient Selection for Secondary Cytoreductive Surgery in the Setting of Recurrent Endometrial Cancer. So thank you once again, Anne, Roni, for your time and for submitting your article and for sharing your discussions with us in our journal club.
Thank you all so much for listening and for asking us questions. And, it's really nice to see others interested in our work. So thank you so much for your time.
Thank you.
All right. Bye-bye. Thank you.